Είμαστε έτοιμοι να προχωρήσουμε με τους επόμενους ξένους ομιλητές. Ωραία. Εγώ θα προλογίσω πρώτα τον καθηγητή Φραντσέσκο Πίτσι, ο οποίος είναι εργάτης στην οφθαλμολογική κλινική του Cleveland στο Αμπουντάμπι. Είναι επίσης αναπληρωτής καθηγητής στο Case Western Reserve University. Εξειδικεύεται στις παθήσεις του αμφιβληστροειδούς και στις οφθαλμικές φλεγμορές και λοιμώξεις. Το τρέχον ερευνητικό του ενδιαφέρον σήμερα είναι το Multimodal Imaging. Σήμερα έχουμε την τιμή να μοιραστούμε τη γνώση και την εμπειρία του στην απεικόνιση και στην εργαστηριακή διερεύνηση της ραγοειδίτιδας. Αν ήταν εδώ live κοντά μας, θα του λέγαμε Professor Pichi, good morning from Greece, good morning from Thessaloniki. It's a great pleasure and honor for being here with us, even online.
Good morning. I'm going to present now on imaging in uveitis. These are my financial disclosure. Now, most of the complications of the uveitis are imaging-oriented, and imaging can tell a retina specialist when the patient, for example, is active, so we can treat the patient, what the patient has based on the pattern of posterior disease, and when to tailor the treatment based on the changes in imaging with therapy. What to use? Well, we have a lot of imaging options for uveitis. We have FA and ICG, OCT, whether EDI or OCTA, ultrasonography, and then photography with red-free and photophotoFluorescence. How can we choose imaging for uveitis patient? Well, based on the site where the inflammation is, it's the best way to choose on the imaging modality. I have to admit that I rarely pick the wrong imaging modality in uveitis because I end up most of the time ordering a lot. Angiography for patients with intermediate posterior panuveitis. I add ICG if there's choroidal involvement, OCT for those with CME and macular disease, and posterior uveitis because I look for pattern, and then autofluorescence for posterior uveitis. Now let's start looking at fundus autofluorescence. As you know, fundus autofluorescence is very useful in posterior uveitis. There's a lot of overlap with ICG and OCT, but it's very useful, especially in the wide field form. The principle of autofluorescence is that it visualizes lipofuscin at the level of the RPE, and therefore, mainly in uveitis, when you have an hyperautofluorescence edge, it means that the edge is active, and it's due to high turnover of photoreceptors. But it's not always that. In my mind, there's three main causes of hyperautofluorescence in uveitis. The first one is an unmasking of the normal RP autofluorescence due to diseases of the photoreceptors, like in mutes. Mutes lesion are hyperautofluorescence because there's an attenuation of their photoreceptors and an increased visualization of the underlying RP, which is sometimes mottled. The second cause of hyperautofluorescence in uveitis is an accumulation of inflammatory infectious debris, like in ASPPC, for example, where the placoid form of syphilis present with nodularity of the RPE that present an increased hyperautofluorescence. Third cause of increased hyperautofluorescence is the increased photoreceptor turnover and macrophage activity at the edge, which is the main cause of hyperautofluorescence that we are aware about. For example, it's very common at the edges of Azor, edges that are active and will increase, or in some cases of multifocal choroiditis. These active edge on your left are actually increasing in size 10 months later. Let's look now at OCT. We have a lot of OCT to pick from, and OCT, of course, in uveitis is very useful in detecting CME and detecting its resolution, and at the same time in detecting inflammatory CNV and its response to treatment. But actually, OCT is the Swiss Army knife of an ophthalmologist, and it can be the Swiss Army knife of an uveitis specialist because OCT reflects the histology. Let's look, for example, at VKH. In VKH, OCT reflects the retina folds with elongation of the photoreceptors outer segment, the large subretinal fluid pocket, a thickened choroid with increased choroidal vessels. Second feature of VKH that OCT can pick up is the presence of Bell-in-Fox nodule. RPE here basically refract the histology with disruption of the RPE on OCT and the extravagation of hyperreflective material. The group of Milan and Sydney, led by Alessandro Vermizzi, has done tons of study on OCT in viral necrotizing retinitis, and OCT is able to detect the disruption of the retinal structure and lacunae within the retina. The OCT hyperreflectivity and disappearance of the normal anatomy of the retina is reflected in a full thickness retinal necrosis. Through OCT, we know the spreading of viral retinitis can happen in two ways. The full thickness necrosis starts from the choriocapillaris. There is a thickness choriocapillaris and RPE involvement, and then these lines that can presumably represent inflamed Mueller cells. So the virus is spreading from the choriocapillaris towards the inside of the eye. While the cavernous necrosis, the spreading is through the retina vessels, and it spreads laterally. With a normal and intact RPE and a normal choriocapillaris. Why is it important? Because the full thickness necrosis usually ends with the formation of a scar because the RPE is involved and damaged. While the cavernous necrosis, usually there's no RPE involvement, but it's more likely to detach. Let's look at toxochororetinitis. This patient in fundus evaluation has an old pigmented scar, a non-pigmented recent scars, and an active focus. On OCT, the active focus reflects the retinochoroiditis nature of this infection, where there's full thickness retinitis and involvement of the choroid as well, with the hyperreflectivity and infiltration, loss of the vascularity here. OCT can actually give us a hint in differentiating viral from toxo, because in viral, there's no choroidal involvement, for example. In toxo, there is choroidal involvement with the back shadowing here. What about choroidal granulomas? Well, the choroidal granulomas are localized at the level, of course, of the choroid, and they consist of a clot of inflammatory cells. The gold standard to detect them is ICG. But in recent publications, there's been a great interest in EDI-OCT in detecting choroidal granulomas. EDI-OCT can detect those granulomas as hyporeflective areas. And what's very important is that in the background, there's an increased transmission that's not present, for example, in other masses of the choroid. What about OCT in endogenous Candida endophthalmitis? OCT of Candida has two patterns of spreading: the migration through the retina and the migration from the choroid. The pattern one, it becomes in our left side, it comes from the retinal circulation and points towards the vitreous. Candida always goes towards the vitreous. The second pattern starts from the choroid and aims towards the vitreous with a disruption of the whole retina anatomy. The pattern one, it ends up with no scar because the RPE is not involved, while the second pattern, since it creates a break through the retina, ends up with a scar formation. Fluorescein angiography is the main and longest known imaging modality for uveitis. It identifies ischemia, neovascularization, and leakage. For example, this is a patient with fern-like leakage and posterior intermediate uveitis that resolves with treatment. But then FA and the wide field FA, they pose some questions. So especially how much leakage should we tolerate in the very far periphery as uveitis specialists? Like this patient with IBD, 20/20 vision, would you treat just this mild leakage? No, of course not. But then the patient comes back six months later. What about now? Would you treat it or not? Well, in recent years, I've become more aggressive in treating leakage because I've dealt with a lot of peripheral changes due to chronic leakage from vessels, like peripheral retinoschisis and the formation of vasoproliferatory tumors secondary to intermediate uveitis and chronic leakage from vessels. And I do become more aggressive in treating this leakage because I've seen with my own eye that treating the leakage, the schisis improves, like in this patient. Of course, FA is very useful for ischemia as well. This 29-year-old patient with lupus is symptomatic. 10 days later, there's ischemia and gets treated with laser. And finally, ICG. ICG looks at the choroid and highlights choroidal lesion that cannot be missed. Hyposenescence is the go-to feature for uveitis specialists, and we're going to look at three main causes of hyposenescence in ICG. The first one is choroidal granulomas. We saw it before. Choroidal granulomas, they represent masses in the choroid and they prevent the distribution of the ICG dye. And they can be reflected very well on OCTA, which will in the future may in the future become the modality to surpass ICG in detecting choroidal granulomas. Very useful in detecting a birdshot lesion is ICG, and I encourage all of you who deal with birdshot chorioretinopathy to get FA and ICG always in your patient, because FA disease with leakage goes independently from the ICG disease of the choroid. Sometimes all these hypocyanescent masses that we see here, they don't respond to the intravitreal steroids that we put in our patients. VKH is a disease where ICG really makes a difference. When we see this pattern, we need to treat the patient more aggressively. The second cause of hypo in ICG is ischemia, like in AMPI. In these patients, their choriocapillaris ischemia is reflected very well on ICG, and it's corresponded on OCTA as well. And the third pattern, finally, it's MUDES. It's a particular pattern of ICG hypo or fluorescence, which is not a true ischemia of the choriocapillaris, because as you can see here, this ICG hypofluorescence does not have a correspondence on the choriocapillaris OCTA, but this ICG hypofluorescence is corresponding very well to the MFAS of the OCT of the RP. So it's been thought that RPE normally absorbs ICG, causing physiological background hyperfluorescence. ICG uptake, however, may disrupt in certain disorders such as MUDES and may explain the late hyperfluorescent lesions. So how do I know if someone is active? I use cells and A's most of the time. It's very important. I use imaging to identify changes that I can follow, and then I can monitor. I then use that imaging test to follow the patient even when they are inactive. Thank you very much for your attention.
Να προχωρήσουμε καλύτερα και στη δεύτερη ομιλία και να κάνουμε τις ερωτήσεις συνολικά.
Good morning. I'm going to present on how to tailor lab testing in uveitis. These are my financial disclosure. Now, the take-home point of this presentation is when you order lab for uveitis, you have to think simple and think broad. We are all aware that ordering lab tests for uveitis must be based on your physical examination, clinical examination, and the history taken for the patient. In general, it doesn't make sense to order a test if the result of the test is not going to change your treatment of the patient. You should prioritize testing for specifically treatable diseases. And unfortunately, you have to make peace with the fact that most of uveitis is idiopathic. Overall, the three most common laboratory testing for uveitis that we should all get is syphilis, TB, and sarcoidosis. We have to check for these entities because they can masquerade and can present as everything. In addition, additional testing should be based on the history and examination finding, as we just said. So let's say the patient has a low back pain. Probably it's a good idea to order B27 and an X-ray of the sacroiliac joint. Let's say the patient has creamy white fundus lesion, then probably best to order HLA-A29. In cases of vasculitis or scleritis, let's prioritize ANCA, ANA, rheumatoid factor, urinolysis, and ESR and CRP. And also consider emerging infectious diseases depending on where you practice, West Nile, dengue, chikungunya virus, for example. You have to distinguish infectious compared to non-infectious uveitis. Look for clues that can point towards infection, like exposure, traveling, hobbies, practices. Ocular clues can be, for example, an elevated intraocular pressure. And then, of course, look for areas of retinitis in your fundus examination. Let's start with the three main lab tests that we order. Syphilis is the first one. My advice when you order syphilis testing is search for posterior segment patterns, which is going to make the diagnosis easier and the lab testing more targeted in this case. There are two algorithms reported by the CDC. One is the traditional algorithm where you order a non-treponemal test first, like PDRL and RPR, and based on this result, if positive, you confirm with a treponemal test, like FTABS. Reverse algorithm, you start with treponemal, so like syphilis IgG, and then if positive, confirm with an RPR, so a non-treponemal test. What's the difference? Well, reverse algorithm is much cheaper. It can detect previous treatment, but it can only be used in low prevalence prevalence population. For example, where I'm practicing in Abu Dhabi, where syphilis is very low, reverse is my go-to algorithm for syphilis. You always have to treat, as you know, syphilis as neurosyphilis. And what I mean by let's look for clues in the posterior pole, well, there are multiple imaging or dilated fundus examination clues of ocular syphilis, like superficial retinal precipitate, multifocal retinitis, confluent or placoid retinochoroiditis, and neuroretinitis. What about TB? Well, most of our tests for TB are just for exposure, so for latent TB. We have two main tests, quantiferon TB and the T-spot. Quantiferon TB basically looks for the quantity of interferon gamma that's produced after exposure to 3 antigen of Mycobacterium tuberculosis, while T-spot looks at the number of peripheral mononuclear cells that will produce interferon gamma after T stimulation. My approach for TB, I test most patients. That's because I practice in an area that can be considered endemic for TB. I use quantiferon, and then I base my results on the uveitis and a systemic evaluation. For example, let's say I have uveitis and a quantiferon positive. The TB is systemically active, then we get a full treatment of 9 months. Let's say the TB is not systemically active, then it starts a long discussion with infectious disease. If the findings are suggestive, like exposure, clinical findings, X-ray findings, then the patient gets 6 months of full TB treatment. If the findings are not suggestive, but still the quantiferon is positive, then the uveitis is active. I treat for latent TB guideline if the patient responds to steroid. If uveitis is active but does not respond to steroid, I still go for 6 months of treatment of TB. If the uveitis is inactive, again, I treat for latent TB guidelines. What about sarcoidosis? Well, sarcoidosis is very, very common in the US and it's getting more common in Europe. Well, the go-to test for sarcoidosis is a chest CT, which is a 96% of sensitivity. It's been proven in a lot of papers. Unfortunately, most insurances will not cover chest CT straight away, so you have to go first for an ACE and a chest X-ray. So how do I work up the uveitis patient in this area? I take a proper history, review of symptoms, and then I do a careful eye examination. I never go for a shotgun approach because it will give me some false positive, some positive results, which will just derail my thinking. And then don't forget about masquerade and alternative diagnosis. Don't forget to check syphilis and TB. And if I measure HLA typing is only 27 in A29 and based on the ocular findings. ANA, I only order if JAA or lupus are in the picture. Rheumatoid factor only in scleritis and PUK. I never order it for uveitis. I've found myself ordering a lot of beta-2 microglobulin in pediatrics or teenager patients. Let's not forget about invasive testing like paracentesis for PCR in cases where you suspect HSV, VZV, or CMV, vitreous stop, and diagnostic vitrectomy in cases of masquerade. What are the most common mistakes in the uveitis workup? Let's look at some cases. The first mistake is when you order the wrong test. You cannot make the diagnosis if the wrong tests are ordered. This is a 68-year-old with a recurrent iritis of left eye. Keeps happening when the Pred-Forte is stopped. IOP is responding to Pred-Forte. Well, the workup here done by the treating physician, you can see it reported here. And what are the necessary testing? Well, all of these. B27 is a necessary, quantiferon gold, RPR, ACE, ANCA, ANA, Lyme. They're necessary because the patient looks like this. So there's an iris transformation defect. A PCR is positive for VZV, and the patient is properly treated. Viral anterior uveitis, you have to look for a clue like IOP spikes, KP or pigment on the endothelium, erythroid atrophy, and transilluminations. The second mistake is the failure to order the correct test. You can't make the diagnosis if the test is not ordered at all. This 39-year-old woman comes to ED for a red eye. 1 week later, the vision is worse, so it's being referred for choroidal scar in both eyes to an ophthalmologist. The ophthalmologist starts Pred-Forte and then order this blood work. What are the unnecessary tests? Well, all of these are unnecessary, but most important is one test missing. So the patient is technically workup negative, so the ophthalmologist starts giving intravitreal Ozurdex in the left eye. Since there's no response, then he gives a second one after 2 months. So after getting worse, the patient is then started on prednisone 60 milligram, and the new inflammation then starts in the right eye. So the patient is sent to us for a second opinion, and here is how the patient look. Very inflamed in the left eye with vitritis, vasculitis, and multiple retinal scar with active foci, and slightly less active in the right. This is the fluorescein angiography, and of course at this point, vitreous tap shows PCR positive for toxo, and toxo IgG are very high. The patient is then properly treated and recovers very, very well. Number 3 mistake is ordering unnecessary tests. Do not base treatment on test results. You must treat the patient based on your clinical findings. You have to think critically about which test to order. This patient, for example, is coming for a left eye involvement. The left eye vision is down to 2200, and this is the test that's been done. The MRI is inconclusive, and toxo is positive for IgG. This is an unnecessary test, but it's getting the ophthalmologist into the wrong diagnosis. So at this point, you can see here the OCT appearance. With OCT is even more diagnostic than lab work. You see the choroid is literally like cystic, and the choroidal vasculature is completely masquerade by some kind of infiltration. On FA, no, just some late diffuse, very mild leakage. And on ICG, you can see there are tiny, tiny faint dots on the choroid. B-scan shows some choroidal involvement, so the left eye is probably most consistent with uveal lymphoma, not with toxo, like the blood work was bringing us to think. So uveal lymphoma is a clinical involvement of the right eye on ICG. There's limited extraocular involvement, cannot do a biopsy. The patient responds very well to treatment with the radiotherapy, and the choroid goes back to normal. Now, what's number 4? Common mistake in laboratory for uveitis. Not everything you see will be uveitis. Like this patient, 28-year-old female with 4+ cells in the anterior chamber, very high IOP. You see how many cells in the anterior chamber, but then you see how the iris and the angle look. So this is a pigment dispersion syndrome. Finally, failure to take a proper history is the number 5 mistake. You have to do a proper history to tailor your lab. This patient is a 47-year-old male treated for recurrent arterial uveitis in one eye, resistant to treatment. He has heterochromia, and he's referred for second opinion. He tells us on a critical review of system that he had a corneal foreign body removed, and he was working as a mechanic. Now on B-scan, there is an intraocular foreign body in the ciliary body that was not visible on exam, and it gets surgically removed, and it's an iron foreign body, which is causing sideremia of the eye, and this is not a secondary heterochromia. I thank you very much for your attention.
Thank you very much for your presentations. Υπάρχουν κάποιες ερωτήσεις για τις δύο ομιλίες του καθηγητή Pichi? Έχει κανείς να ρωτήσει κάτι? Να ρωτήσω κάτι εγώ. Good morning from Greece.
Good morning, everybody.
May I ask you something? Is the result
absolutely, yeah.
Is the result of positive or negative PCR test always reliable or not?
It's a great question in the COVID area, actually. Well, I find that if it's positive, for me, it's reliable. If it's negative, I still consider the whole picture. And it's not always that I get PCR, for example, for toxo. If you have a great clinical picture with scar, I don't usually take PCR. I do some lab testing, but I don't use PCR in their cases.
Oh, thank you very much. And I have a second question also. Do you prefer to perform an AC tap in a quiet eye or in an eye full of cells?
In both, actually. In an eye full of cells, I'm quite sure that I'm getting a lot of white blood cells, but we're not looking for that after all. We're looking for viruses or protozoa. But to me, it's exactly the same. So if I feel that an eye has an inflammation or an infection, I go for the tap if needed.
Thank you. There is also one more question from Professor Androudi.
Yeah.
Hi, Francesco. It's nice to have you with us, even virtually.
Thank you.
Your talks
thank you for
were
the invitation.
great. Your talks were great. I have one question. It's, I think we all know that toxo is a clinical diagnosis, right? You said it before that if you have the clinical picture, you don't go for a PCR test. But you go for the blood workup sometimes, not always.
Yeah.
So if a patient, you have the typical clinical picture and you have a negative IgG and a negative IgM toxo, do you still think it's toxo? I mean, does a negative IgG rules out the toxo diagnosis?
I think it's a great question. IgM, if it's positive, okay, we all know it, but if it's negative, we cannot rule it out. IgG, if it's negative, I need to rethink everything because I don't see any reason for IgG to be negative if the clinical picture is pointing to toxo. So I also employ in these cases OCT because I've shown in the presentation, and like Alessandro and I, we use it a lot. OCT can tell you at which level of the retinal core the infection is. So let's say, for example, IgG is negative. I do an OCT over the focus, which I think is toxo, and there's no choroidal involvement, then I rethink everything. So IgG negative worries me about the wrong diagnosis in such case.
Thank you.
Thank you very much.
Αν δεν υπάρχει κάτι άλλο, να χαιρετήσουμε τον καθηγητή Pichi. Thank you very much.
Thank you.
Thank you. Have a nice weekend.
Thank you very much.
Thank you. Goodbye.